Good evening, everybody, and welcome again to the Asian Geriatric Oncology Society webinar series. Today, we are on webinar 2 and taking a very important, pertinent topic of early diagnosis of cancer in older adults. It's something which is always sort of emphasized on, but at the same time, a lot of times is not concentrated on maybe by the older adults themselves. And we don't want to be in the cliche thought of, yes, I mean, as they show sometimes in the movies, that you should have come later, which is not something we all at any point say as doctors. But yeah, I mean, early diagnosis is very important. And we have, of course, today with us uh, Dr. Tilak, who is going to sort of uh, tell us about the same. Just a brief intro about him. He is basically a medical oncologist who, of course, is from the defense background. He's currently in Bangalore, and he also played a very important sort of role in learning geriatrics himself, which is obviously something which just adds to this webinar as well. So thank you, Dr. Tilak, and welcome. You are good to go.
Thank you, Dr. Prem, for this kind words of introduction. I shall just share my slides. Just some issue with the... I will just join you back. Give me just some system settings. Is my screen visible?
Yes, sir.
All right. Sorry, there was some issue of permissions. It got kind of delayed. Right. So without wasting much time, I would like to thank Dr. Prem for the kind introduction and EGOS for giving me this opportunity to talk on a topic, early diagnosis of cancer in the elderly. So my outline of the talk is going to be cancer and aging. Are they actually related? What are the common cancers in the elderly? What age do people usually get cancer? In early diagnosis, which means screening of cancer is beneficial in the elderly, and what is the current evidence in screening guidelines for common cancers in the elderly? So if you see aging and cancer, they're essentially the two sides of the same coin. So the P53, the housekeeping gene, which kind of guides towards the prevention of cancer and maintenance of the cell homeostasis, is acted upon by the alternating reading frame and the collaborator of the alternating reading frame, the CARF, etc. And they kind of help P53. Any DNA damage or a DNA repair activates P53, and that leads towards cell senescence. The senescence associated secretory peptide is one of the ones which also gets activated as the cell goes into senescence. And based on the effect of the antioxidants, the pro-inflammatory cytokines, etc., the balance between these two, and the immune system, which acts both the innate as well as the adaptive immune system, whether the cell eventually goes into a cancer level growth or a pathway or into cell senescence pathway is what decides the fate of the cell. So effectively, they're actually two sides of the same coin, guided by various factors. So in this picture, you can see on the x-axis is the time and age as it advances. And as we can see, starting from the left top, the host resistance goes on reducing as we age based on the reduced immune surveillance, the reduced ability to repair the DNA, the telomere shortening, the microenvironment imbalance, etc., and apoptosis resistance increases. And slowly, other factors come into the initiation of cancer, like the free radicals, the carcinogens, and the viruses. And at various time points, as you can see, there is oncogene activation or mutation, which can occur like this, a tumor gene suppressor loss, an apoptosis gene loss. And this leads to a pre-malignant state, leading to promotion of the cancer, eventually leading to angiogenesis and metastasis and progression of the cancer. So it is important to know what is the effect of the aging physiology on the cancer with respect to the treatment part of it. So as we know, with aging, there is reduction in the cardiopulmonary physiology. There is reduced VO2 max, reduced cardiac output, reduced elasticity, and this can affect the patient towards the surgery and the cardiopulmonary toxic drugs which are used in cancer treatment. The reduced skin healing can cause delayed wound healing in surgery. Effects in the CNS can lead to patient's interaction as we clinically follow them, as well as the toxic drugs which enter the CNS. Loss of special senses can affect in the nutrition and the radiation therapy. And similarly, the hematopoiesis and the reduced immune system, as they reduce, we have effects of the chemotherapy and radiation on the bone marrow recovery, as well as infection rates, the drug distribution, the hepatic and the drug renal metabolism because of reduced functioning of these organs with aging physiology. And the outcomes of cancers, broadly, when we practice oncology, we see, okay, fine, on one side, we have the tumor development and tumor biology. On the other side, we have the cancer treatment. What are our choices? What treatment do we give? How much does the patient tolerate, and the efficacy, etc. It decides the outcome. And when it comes to elderly, there are two other factors, that is aging and frailty in their own way. So aging with all its physical, genetic, and metabolic pathways, and frailty with all the components of it, can independently affect both the development of the tumor and its biology, as well as cancer treatment, and affect the overall outcome. And so this is very important to understand in geriatric oncology. And if you see the worldwide cancer incidence of age 60 years and above in both sexes, if you see just the AGOS region, the Asian and the Asian Geriatric Oncology Society region, you can see that by and large we are about much lower than the Western world, almost close to 1/3 of the incidence of cancers, even in the elderly. And similarly, the mortality rates are slightly more than the half of what is there in the Western world. If you see the age standardized mortality rates in elderly above 60 years of age. And what is the probability of the elderly developing cancers by group age-wise? This graph from a study done in 2022, we can see that the males, they continue to have a progressive rise in increasing cancer with aging, whereas women, somewhere around the 70s and early 70s, they kind of plateau out towards the development of cancers. The common cancers in the men, as is world over, it's basically prostate which rules, prostate and lung. But somehow in the Indian subcontinent, we have the lip and oral cavity because of the use of tobacco in various forms. And a few of our neighboring countries, of course, have lung still as the primary common cancer. In the women, it's again the breast cancer. But somewhere in Southeast Asia, there's some areas where we have lung cancer still as a common cancer among women aged 60 years and above, probably because of the smoking habits. So the cancer in older adults does become an increasing cause of death in men and women aged 60 to 79 years of age. 50% of all cancers and 70% of all cancer-related deaths occur in people 65 years or older. And the estimation is that in another 5 to 6 years, more than 70% of all cancers will be diagnosed in people over 65 years or older, and hence the importance of geriatric oncology. So for those who are uninitiated in the non-oncology field, how do you suspect if somebody has got cancer? This applies to all basically, but more so in the elderly. Just remember caution: any change in bowel bladder habits, a sore that does not heal, unusual bleeding or discharge, a thickening or lump anywhere, indigestion, an obvious change in the wart or a mole, and a nagging cough or hoarseness. A brief overview of these symptoms in the OPD in the elderly can bring to notice whether this person might be having cancer or not. This brings to the question of, do we screen for cancers in the in the population? So it does affect the early detection of cancers, as well as mortality in earlier age groups. But in elderly people, especially more than 70 years of age, they are rarely included in most of the studies. Lately, they've been started including the studies, but as a subgroup analysis only is the data which exists. And this particular question, whether cancer screening helps and its efficacy remains controversial. We know that cancer increases with age, but is routine screening in elderly advisable or appropriate is the idea of discussion of today's talk. So apart from some of the cancers for which there is evidence, for example, breast, colorectal, lung cancers, there are harms of screening of cancers in the elderly. If you do it on a large population-based scenario, you can have fatigue from the test, the discomfort, the adverse effects, the harms of the procedure after care. It's time-consuming and distraction as compared to their goals. So these needs to be considered for across the board cancer screening in the elderly. What is surveillance screening? So surveillance screening is a routine screening in the absence of symptoms or abnormal physical findings for recurrence or a new primary cancer of the same type as the cancer survivor's prior cancer beyond the routine history and physical examination. So these are people who have already had a cancer and right now are fine. So you just keep them under surveillance for a new cancer or a recurrence. If the patient's life expectancy is 5 years or less, they're unlikely to benefit from routine surveillance testing. And so once a person has been treated, probably surveillance screening becomes very, a debatable topic in these patients. But if the patient's life expectancy is greater than 5 years, then individual shared decision making, especially with the goals and values of the patient, the wanting of treatment in case a cancer is recurrence is diagnosed, the appropriate health status, and all these needs to be individualized for surveillance screening. The benefits of cancer screening are likely to exceed the harms if the risk of cancer is higher than the average. That is, the patient has got some genetic cancer syndrome or a prior exposure to a chemotherapeutic drug or radiation, and the life expectancy is sufficient. So this is overall regarding the surveillance testing in elderly patients. There are, of course, some barriers to screening. The patient's comorbid illnesses, his poor functional status, his mobility issues and poor social support. And if there's cognitive impairment, how much can we push them towards screening for cancers is again a very debatable question. And so just age matter for screening. So you got to balance the overdiagnosis and the treatment versus benefit. And presently there is no evidence that benefits of that screening stops at a particular age. You know, whether we should stop at 60, 70, 75, 80, we do not have exact data available except for very few retrospective subgroup analysis. And strict age-based screening guidelines, they often underemphasize the benefits in a healthy 80-year-old.
Dr. Tilak, sir, can you hear us?
I think we're just momentarily lost connection. Let him talk. Let him rejoin. So
Sir,
you're
you
on
will have
mute.
to unmute yourself.
Yes. Am I audible now?
Yes,
And
sir.
slide visible?
Yes, sir.
Yes. Sorry again, some connectivity issues. So is there a lag time benefit? And they said if there are 1,000 participants and time for at least one reduction in mortality from start of screening, if that is the kind of benefit you have, then probably for breast and colon cancers, the duration is 10 years. So if somebody has a life expectancy with respect to about 10 years, then probably it's a good time, a good thing to screen them for breast and colorectal cancers, and hence the guidelines in the elderly. That's what led to the current some guidelines in the elderly. So the NCCN says that if a patient's life expectancy is less than 10 years, he's unlikely to benefit from routine cancer screening, and so you should stop screening. But if the life expectancy is more than 10 years, then you assess the patient's goals and values. Is he willing for it? And so if he's unwilling for it, you stop cancer screening. If he is willing for it, engage in shared decision making, and then go along with cancer screening methodologies. So let's come to a few of the common cancers which can be screened in the elderly. So in colorectal cancer, we know that the adenoma carcinoma sequence takes about anywhere close to 5 to 25, sometimes 30 years. And if colonoscopy is done in the elderly, polyps are found about 20 to 25% of the cases in about 50 years, and in above 75 to 80 years, more than 50% are likely to have polyps, and only about 1 to 10% will progress to cancer in 5 to 10 years. And the various modalities which are available are, of course, the fecal occult blood testing, the fecal immunochemical testing, fecal DNA testing, sigmoidoscopy, colonoscopy, and CT colonography. What do the guidelines say? Current guidelines say that there are false positives of fecal occult blood testing, and so it alone may not be enough for screening. Colonoscopy, the reduction is 50% or less in incidence if colonoscopy done 5 years or more since last endoscopy, and this increases to 63% reduction if done less than 5 years. Of course, there are procedure-related risks and challenges with bowel preparation. The US Preventive Task Force recommends screening for colorectal cancers in adults aged 50 to 75 years. Data from India is currently not available for across the board colorectal cancer screening in the population or the elderly. Prostate cancer, similarly, the high-risk disease is very, as the age increases, the probability of a person having a high-risk disease keeps on increasing. The methods are, of course, digital rectal examination and the prostate-specific antigen. The European randomization study for screening for prostate cancer says that in 50 to 74-year-olds, every 2 to 4 years, and with a 13-year follow-up, led to a 20% reduction in the overall prostate cancer-specific death. And these benefits, however, restricted only to 55 to 69 years on randomization. So what are the harms of PSA scanning? About 30 to 40% of them have a false positive and eventually have unnecessary biopsies. Many of the other causes which lead to high PSA. There's moderate to severe pain in 6 to 7% and moderate to severe hematuria in about 6% of patients going across the board screening. So the US Preventive Task Force recommends against PSA screening for prostate cancer in men 70 years or older. It says that it's not a routine to do a PSA in every person who is 70 years or more, unless there are specific symptoms. Coming to breast cancer, more than 70 years, the diagnosis is seen in about 31% of all cases, and it contributes to deaths in about 47% of all age 70 years or more. Mammography, up to 70 years of age, reduces mortality in 19%. However, in more than 70 years, the benefit is not certain. The sensitivity of mammography, because of reduction in the fatty tissue and increase in the fibrous tissue of the breast, increases with age. There are fewer false positives. There is again insufficient clinical examination against or for clinical breast examination, and the Preventive Task Force recommends biennial screening mammography for women aged 50 to 74 years. For lung cancers, more than 2/3 of the cancers are diagnosed in elderly beyond 65 years of age. The low-dose CT study, the trial showed a 16% relative reduction in lung cancer mortality after 6.5 years, and a 6.7% reduction in all-cause mortality. There are risks of screening with the low-dose CT. The false positive and the false negative rates, about 40% of patients with 3 annual low-dose CTs had at least one positive test, and 96% of these results were false positive. So again, the guidelines do have their limitations. There is, of course, radiation exposure and financial strain of doing low-dose CT. So what do the guidelines currently say? 55 to 74 years of age with a more than 20 pack years smoking history and a good life expectancy, annual screening with low-dose CT can be recommended. And if the person has left smoking for more than 15 years, we need not actually screen them for lung cancer if they do not have any symptoms. So a cancer-specific guideline as per age can be consulted. We can discuss with the patient's preferences, whether he wants more or wants less. and then based on the comorbidities and the family history, etc., use prognostic calculators. And if the life expectancy is more than 10 years, we can have a shared decision making on screening for cancers. What about these various online web tools which are available? They're available for various cancers, both for physicians as well as patients. It is suggested that well-known calculators from dedicated sites of cancer, for example, the NCI, the MSKCC, or the Mayo Clinic, can be used in cases, but not the routine across the world, what you call as Dr. Google kind of tools to screen cancers. What are lessons from pandemic? So during the pandemic, such were the numbers of drop with respect to mammograms, colonoscopies, pap smears, and PSA testing. With such high numbers of drop in these kind of things, what happened to the mortality rates? They were definitely much, much less than the deaths from COVID-19 by itself. And if you see the deaths from other causes, what were, this is again a US-based data, that the deaths attributed to excess causes above the normal were predominantly diabetes, Alzheimer's, hypertension, pneumonias, coronary artery disease, stroke, sepsis. Cancer-related deaths have not been reported as over and above the normal in this, even in the pandemic scenario. So again, screening comes to a very, very kind of a debatable issue in the elderly. So early detection of cancer in the elderly can be challenging. Aging and infirmity often attributed to early symptoms, and hence we need to look at these symptoms by using the caution list and finding out whether the person can actually harbor a cancer or it is just purely aging which is causing his symptoms. And the screening method for cancer detection, not to be used blindly. The country policies and guidelines are helpful. As of now, in our country, we do not have strict guidelines for screening of cancers in the elderly. The screening guidelines are present only available for cervical cancer screening, and that too in the younger age group. We need to keep in mind the life expectancy, the family history, and genetic predisposition, the wants and needs of the elderly to be considered before screening of cancers can be suggested or given to the patients when they ask for such things. With this, I would like to end my talk. And if there are any questions, I'll be more than happy to take.
Thank you. Thank you, Dr. Tilak, for the eloquent talk. And as they say, there could be a bit of network issues, but that's okay. We have overcome that. If there are any questions now, we can take them, or we can just dive into the case-based discussion and then take the questions at the end, if there are none as of now. Okay, so I think I will sort of go into the case-based discussion. Before that, I'll just want to introduce my panelists. Of course, we have Dr. Tilak, of course, who's going to join us in the panel as well. Then we have Dr. Nitin Yashas, who's obviously he's a medical oncologist from Manipal Hospitals. He's a very young and upcoming oncologist who shares a common passion of cricket with me. So, I mean, we have quite a bit of topics to discuss amongst ourselves. Then, of course, Dr. Marnik, who is who has been one of my colleagues in AIIMS New Delhi, and currently, of course, he is a geriatrician who is working with Geriatric hospital, and who are doing a great job in actually sort of establishing ecosystem as far as geriatrics is concerned. So welcome aboard all the panelists. So as I said in the last webinar, we are obviously going to delve into more of a case-based discussion. So I'll be just presenting mostly maybe one or two cases depending upon the time. And yeah, Manchi, can I share my screen? I'm not. Yeah.
Yes, sir.
Okay, and thank you, Dr. Tilak, of course, for helping with the cases as well. So these are not These are not created cases. These are cases which are sort of been delved in practice. So some of the pertinent issues in geriatric oncology, which a lot of time we sort of have to deal as oncologists and even as geriatricians, is cognitive impairment. So I'm just trying to highlight a few to set the scene. So we all sort of look at it. So, I mean, before I go into the case, let me get Dr. Manik here. So, how difficult or easy is to deal with cognitive impairment, and how complicated will it get with a patient with cancer?
Thank you, sir, for the opportunity and the generous introduction. And regarding the cognitive impairment, there are two questions are coming up. Whether the patient, first thing is whether the patient has the capacity. Second thing is patient without the capacity. So in patients without the capacity, who is the surrogate decision maker, whether they were able to make the decisions in the best interest of the patients or not. And in patients with capacity, we have to assess which stage of cognitive impairment he is in. All those with dementia cannot be written off, or they are not able to make the decisions. It's nothing like that. Which stage of cognitive impairment they were in, whether the cognitive impairment they are having is whether it is reversible or not. So we have to answer these questions, then only we can make the decisions.
I think very pertinent. I mean, just to get Dr. Nitin into it, in the Indian setting, a lot of times there is already surrogacy wherein the older adult doesn't even know their sort of diagnosis. So, I mean, a lot of time cognition does not come. I mean, your experience, I'm sure it might not be very different.
Yeah, true. So, like even today, for example, 78-year-old diagnosed with CA prostate, the family first came to me and don't tell him anything. Tell him it's some
Very
sort of
common.
infection near the kidney. So I think there's a lot of cultural and social stigma with cancer, which we deal with, even with the elderly, especially, that they don't want them to be aware. Even it doesn't matter what the educational status is. They don't want them to be aware of it. So that's a challenge we all face. And the second, with regard to cognitive impairment, and this was a sort of a small study I was a part of during my residency, and we also know about chemo-related cognitive impairment and sort of the chemo brain fog that we saw. And sometimes using certain validated scoring systems will help keep that in check, and also help us to take any preventive or interventional measures to prevent it from becoming further worse.
Yes, Dr. Tilak, if you just want to add anything to it.
Yeah, so like Dr. Nitin and Dr. Manik have suggested, it is an important aspect, and more so when you have a multimodality treatment where you have used whole brain radiation or a stereotactic radiation to 3 or more lesions, that further adds to the cognitive impairment. And sometimes our radiation oncologists preemptively start them on memantine, etc., when they give a whole brain radiation to an elderly patient. So that also adds to cognitive impairment along with the drugs.
Yeah, I think it's very important, and I think it was very important that Dr. Manik, of course, highlighted the mental capacity part, because as geriatricians, I'm sure Manik can vouch for it. We experience a lot as far as even legality is concerned, dealing with wills, because mental capacity becomes very important in the same.
I just had one sort of small case which I just remembered, because you talked about the mental capacity. So there was a 77-year-old lady, CL lung with brain mets. She had a ROS mutation and she had underlying schizophrenia and depression also. And it is these kind of cases which, again become challenging as to what is really the mental capacity. And surprisingly, she responded very well to this oral tablet called lorlatinib, which we had. Exactly. And then developed severe neurocognitive impairment. She had leptomeningeal meds. Everything came down. CA came down from 100 to 10. But the family came to me and told, patient is reporting she's seeing people jump out of the TV. She's seeing people sitting on the fan. She's asking her 45-year-old son, why you have not done the homework? And then and this is something which we know is associated with lorlatinib, as Dr. Tilak would also agree with it. And when I read up the paper, drugs like lorlatinib cause more cognitive impairment in patients who have underlying brain mets or a psychological or psychiatric disorder. And this was a lady with classical example, and I stopped lorlatinib for 2 weeks. her cognitive and sort of psychological symptoms improved, but then the disease just went up in a flare, and then we lost her this thing. So again, like everyone is saying, it's a really, even cognitive impairment, though we might think is just one aspect, actually has a lot of multimodality management of it.
Yeah, absolutely. And I think, as Dr. Nitin highlighted, I think that would be one of, that's usual the case where we have to decide risk benefit. And a lot of times, we end up sort of giving risk. But it's usually a lot of times against the disease management versus the other domains, which sort of becomes risky. That's why, of course, the geriatrician and the oncologist coming together works. Then, of course, there is isolation. So I think isolation was something which was seen very common, especially during the pandemic. I am not going to dwell a lot into it, but we all, I think, have sort of dealt with it in a way of providing consults. And as Dr. Tilak highlighted, the number of sort of procedures, number of sort of screening also went down during the pandemic. In fact, treatment was also delayed, which sort of has not really sort of helped. Then, of course, uncertainty. So I think it's very important as far as uncertainty is concerned, which is more with, I think, dealing with the sort of disease per se, but at the same time, uncertainty with overall sort of management of the disease as far as we are concerned. Yeah, Dr. Tilak, do you want to add something? Yeah.
So one more aspect of isolation is isolation in terms of partner. At that age, elderly people, when they don't have a partner, they really don't know how much they can share with their children or the caregiver or caretaker. That isolation also becomes pertinent, which is sometimes overlooked.
Yeah, absolutely. So let me come to the case now. So this is basically a 78-year-old homemaker having comorbidities of hypertension, hypothyroidism, left total hip replacement in 2015, bilateral total knee replacement in 2017, presented basically with left flank pain in November 2021, and then PET CT was done. It showed a mass, then 5.8 to 3.8 centimeter, basically in the left ureter, left common iliac artery, abetting the left psoas muscle and left hydroureteronephrosis. So the management, of course, the left nephrourectomy was done, and a high-grade urethral carcinoma, basically P320M0. So, just on the basic history, Dr. Marnik, so do you already see that it seems quite complicated with the comorbidities and obviously...
What I have seen from the description is the 78-year-old lady, a homemaker. So she is likely to be financially dependent, and whether she is living in isolation or loneliness or with the spouse or not, the details are not there. And she is having multimorbidity, evidence from hypertension, hypothyroidism, likely arthritis hip, and there is even underwent care, likely to be a knee arthritis, and left THR. We don't have the data which came from the fracture or arthritis, what led to that. And flank pain, left flank pain, and could be urinary tract infection or something else, maybe arising from the chemotherapy or not. And locally advanced stage of the tumor. So we can see she is multimorbid, homemaker, likely financially dependent lady with limited mobility and limited physical performance, and cognitive status we cannot assess. So these all we can infer from this data.
Okay. So, as sort of the case course of illness, basically metastatic disease was detected in April 2022. So left parotid lymph node infiltrating into the psoas muscle. PD-L1 was more than 1%. So the management, injection pembrolizumab 200 milligram from weekly from April 2022, changed to 100 milligram Q3 weekly from July, and then received the 32nd dose on 7th Feb 2024. Now, interim assessments are showing, of course, PET CT 14 December, CMR with non-FDG avid mass of 1.2 to 1.7, and PET CT dated 1st Feb showed with CMR with non-FDG EBIT mass of 1.4 to 1.5. Now the patient is unwilling for more therapy. So let me get Dr. Tilak first and Dr. Nitin next. So what would be the further course of action as far as an oncologist?
This case actually was treated by us in consultation with one of the empaneled hospitals. And as Dr. Saravanan has mentioned, she was a single lady living with her daughter and with multimorbidity and with this kind of illness. After the recurrence occurred, the pembrolizumab was started purely from a point of view of palliation, that let's see what happens. And here we were receiving 32nd dose and there is no evidence of disease at all. And each time she goes, she has no adverse effects also. She goes, comes back, she says, I mean, her understanding of the whole thing was, I just go take some injection, I come back, nothing happens to me. Nothing has happened to me since then. Why should I take more treatment? This was a very difficult decision for us to take. So at 78, I had to take a call on her goals and values. I said, okay, if you're unwilling for any further therapy, I'll keep you in close follow-up. You've had a complete metabolic response. And we know that sometimes in immunotherapy, which is used in some patients, we do have long-term non-progressors. We don't call them cure, but long-term non-progressors. So there was a dilemma whether to go by the medical science and say you're doing well, continue, or respect your values and goals and say, okay, let's stop and watch. Dr. Nitin, what would you have done?
Yeah, in fact, in the time period that you mentioned for the patients who are paying for immunotherapy, we were in fact even stopping treatment after 1 year. And then we sort of analyzed our data also, and we saw, like you rightly said, the patients who achieve a CR or a very good PR on imaging, they do tend to do very well on the long run. In fact, I think except till this year, with a sort of a median follow-up of, I think, around 3 to 4 years, we only had about 2 relapses out of 20 or 25 odd patients. So I think with immunotherapy, and that's why we are all excited about immunotherapy, because we start talking about the tail of the curve. I think it was only because it was ECHS that she was even able to manage to go on till 32 without worrying about the cost. But I think for most patients, till the recent support program also came in, financial toxicity was a big concern. And when any one of them achieved a very good response, like what was seen in this case, we have stopped after 1 year. And of course, we now have some of the data from some of the original IO trials of Pembro and Nivo, where they say even 2 years is enough. So I think there are two aspects to this. One is the science aspect of this, as to till how long you need to give immunotherapy. But then again, the second and the most important factor that Dr. Tilak mentioned is what are the goals of the patient? I think if I was to just sort of extrapolate it even to an adjuvant setting in some other malignancy where there's no relapse, I think we need to look at the risk of relapse and the risks of treatment, and clearly our treatments should be aligned to the goals of the patient. If the patient who is 80-year-old, do we really need to give adjuvant treatment in CA colon? If the patient says, look, I am happy, it doesn't matter whether the disease comes back to me after 2 years or not, I am happy right now, I don't want any adjuvant treatment. And I think we might all always want to look for the OS purely from a cancer point of view. But I think we, as more and more elderly patients have begun treating, have come to realize that their goals are very, very important.
Very important. Yeah, agree.
I think so. I mean, just let me twist this a bit. So if it was immunotherapy was not on the table because of cost, then how would we proceed? Dr. Tilak. Yeah.
So in case of a metastatic urothelial carcinoma, it would become chemotherapy, the standard conventional chemotherapy. And with this age and comorbidities, it would definitely be dose adjusted, probably not to the best, maybe around, say, 60% of the doses, and slowly escalate thereafter, which we now started using objective criteria of using CA-RG scores and the crash scores to see the chemotherapy toxicity, and the overall dictum being start low, go slow. That's what we would do.
Yeah, and the second question being, what was her quality of life when she actually was unwilling for therapy?
Oh, she was up and about. She was walking. She used to walk into the OPD, assisted by her daughter-in-law, of course. I mean, not like a assisted ambulation, but she used to accompany her. And she used to say, I'm doing everything on my own. Why should I take this anymore? I'm tired of going and lying there and getting a drip into my hand.
Yeah, so Dr. Nitin, just wanted you to add on to the fact that, I mean, a lot of times even when I have seen sort of patients who are on immunotherapy, they obviously are coming, they are taking the immunotherapy, but the sense of actually something happening does not really come in. I mean, it's all basically when we do the imaging part. And I mean, Dr. Manik will absolutely vouch for a lot of time older adults want to see effects which actually sort of can be seen, whether it's maybe better hair growth. I'm just giving examples, or whether it's feeling a bit more fresh, or whether they are sleeping better. That could be a lot. So how do you sort of people who are willing to sort of do immunotherapy, how do you sort of get them on the table to actually understand that there is going to be a difference when cost is not an issue?
Correct. So one thing always I say is sort of narrative medicine or stories of other patients. So I do show them images of other patients, and at the same time highlighting that immunotherapy is still a very, very new thing for us oncologists, even though it's been there for 5-6 years, in the sense that we still are not able to have a good biomarker which predicts who will respond and who don't. But yes, patients do get inspired and filled with hope when they see images and stories of other patients. That's one thing. And second thing for them, the most important thing is we know that immunotherapy does not have the traditional side effects of chemotherapy. So one way to get them on table is to, of course, when you're giving it as a single agent, as was done in this case, when you say that there is not going to be hair fall, not much of cytopenias, no nausea, vomiting, they are very much on board with taking it. I sometimes avoid talking about cost of immunotherapy in front of the elderly because, again, most of them per se feel like they are being a burden to their family, and particularly the sort of especially in one of the Manipals I practice, there's a lot of people who have come from out of station, so they already are ending up feeling like they are visitors or being a burden to their family. So I avoid talking about the cost in front of them. So I talk to the attenders about it in a separate section, and if they agree for it, it goes well. And sometimes I always think treating geriatric patient is almost as gratifying as treating the pediatrics, because sometimes when they see the responses on PET and they see the good thing, they are very, very thankful, and their blessings are something that, always keeps the entire unit and the team happy also as such. So recently there was a 78-year-old with CA esophagus, on Riles tube, metastatic disease, 3 cycles of immuno with low dose weekly chemo, went into complete response. And then he himself told me, Dr. Saab, ab main aunga, har mahina immuno maintenance ke liye aunga. So he comes, takes it and goes. And in fact, I am wanting to stop it. He says, nahi, Dr. Saab, kuch nahi ho raha hai, continue kijiye thode aur. So I think different perspectives from different patients. And again, the basis shall be we align ourselves to that. I just see that you mentioned about IRAs as such, and we sort of looked at almost 250, 300 IRAs, and the most common that we saw was thyroid dysfunction. So we make it a point to repeat the TSH every alternate cycle at least. Particularly sometimes when we combine it with oral tyrosine kinase, the incidence is more. And many times sometimes when we have missed it and patient complains of excessive fatigue, loss of appetite and all, we sometimes say, oh, it's just because of the old age. But it's just when we check the thyroid, then the TSH would be 20, 25 as such. So the most common that we have seen has been thyroid hypothyroidism and skin rash. Some very rare, in an 80-year-old, we had seen immune-mediated retinopathy. And in another patient, we had immune-mediated encephalitis as such. But I don't think we have seen any difference in the spectrum of IRAs between the elderly and the young.
Yeah, Dr. Tilak, just your experience in a setting where usually it might be covered. So, I mean, are people, and maybe people are obviously taking long duration of immunotherapy. So if you can just highlight your experience, and then we can go to Manik. Yeah.
Yes, so two things. One is that we are using immunotherapy quite extensively, both through our empaneled hospitals as well as in our own daycare. The second aspect has been recently published data by my colleague, Dr. Amol Patel from Mumbai, wherein he analyzed the effect of weight-based low-dose immunotherapy, and it got published in Journal of Global Oncology, JGO. And we really have shown that we need not go by the recommended doses as is given in the brochures of the original drug manufacturers. Going by weight-based, 1 mg per kg, even or maybe 2 mg per kg in case you want to be more this thing, has nearly same kind of effect with the similar kind of side effect. There's no difference at all in both the things. So we are practicing more of immunotherapy and definitely weight adjusted and low dose immunotherapy. As regards IRAs, I agree with Dr. Yashas. It is a thyroid, which often we also see. I'm yet to see a case of a severe colitis, as you mentioned, requiring steroids, etc. The other thing like the adrenalitis or a hypophysitis, not yet. I haven't seen any case so far.
Yeah, so Dr. Marnik, I mean, from our perspective, I would say what and how would have actually a geriatric assessment helped in this case? Because a lot of things, I mean, by what I have highlighted, still seems to be hidden. And the fact that she was alone, whether she had the presence of maybe, I mean, she was isolated, whether she had depression, whether she had anxiety, whether what was her fall risk. So how and whether she had urinary incontinence, because a lot of times older adults don't even speak about it unless you're not asked. So your views on that?
Yeah, and I would there is always a preferred before starting the treatment when the patient is treatment naive, go for a geriatric assessment because there can be a lot of hidden things. And as a geriatrician, my job would be helping my medical oncologist colleagues know what are the vulnerabilities in the patient. So if we are coming to this patient, he is having hypothyroidism and hypertension and multimorbidity with limited functional status with limited physical performance due to the knee replacement and hip replacement. So my targets for the treatment, sometimes it can be triggered by the immune checkpoint inhibitors or something like that. So if we are stopping, I would wait for the hypertension or the thyroid status to come down or not, reduce the medicines, not keeping a very tight target, and would assess his fall risk and keeping subject to her to a structured exercise program for fall prevention, and would prefer to do a home visit or home advice to keep the environment safe to prevent the fall. And I would like to get a psychological assessment to assess the anxiety, depression, or whether she is having any kind of dementia, because yeah, depression is good enough to cause good enough to make the impact the decision making. So why is she going on treatment for 1 or 2 years? Then why now she is refusing and she is improving well? And the financial toxicity, who is spending and why she is suddenly refusing? Any stringent, she's whether she was on a tight budget, or is there anything making to cause her to stop? Whether she can be, whether we can be able to get her any financial assistance, and social isolation, where how she is managing, she is living alone here with her daughter. So how she able to make her day-to-day activities, whether she is completely dependent on anyone or independent, depend upon that.
Yeah, I think one of the very important things that you have highlighted is that we as geriatricians help the oncologists to sort of take care of the non-oncological vulnerabilities, so that we obviously know as a baseline, and can, of course, I mean, assessments can sort of also be relooked at maybe during treatment as well, because obviously there are going to be sort of maybe medication related side effects. I mean, one thing that Manik obviously would have want to highlight is the current drugs which the patient might be on, because polypharmacy is also something which, I mean, for our practice is a huge bane. And I know for a fact that oncologists are always worried about the fact that what the current drugs are going to sort of do to the existing drugs as well, which is sort of also sort of can be a problem. So I think we as geriatricians would like to obviously have a prominent role in helping out the oncologists in sort of making that nice tailored treatment, wherein we obviously can be there to shadow the patient throughout the treatment, but at the same time, obviously the prerogative of the oncologist would be to sort of see where the tumor goes, and ultimately tumor boards. And finally, I think what I do is I am able to counsel the patient with the oncologist, so then it becomes easier to get them on board, because lot of patients can have the obvious question that, okay, the oncologist has the role, so where does the role of the geriatrician come? And then when we sort of counsel them together, it obviously helps. So yeah, Nitin, I just wanted to take your perspective on geriatric assessments. One is, do you do it commonly, or is it something which is not routinely done as such, because I remember a study from which was done by in Tata and Bombay, wherein hardly any oncologists actually knew about the fact that geriatric assessments even exist. So yeah, your take
Yeah,
on that.
so I try to do it in my practice, but not often as I would like it to be done, or it should be done. The other advantage I feel, again, in sort of the setting that I practice and in a city like Bangalore with the IT crowd, is when you do a geriatric assessment and you tell it to the relatives, they get more confidence of going ahead with treatment. And I see that one more value add of doing a geriatric assessment. Of course, the medical aspect of it in terms of tailoring treatment and choosing treatment and using tools like Dr. Tilak said to predict toxicities, we have no doubt that it is useful. But I think one thing which I realized is when I take out time and do this assessment and in fact communicate it to the relatives and say, hey, this person is good enough, these are the complications, geriatric things which I expect, and that is why I'm referring you to so and so geriatrician or physician to manage these. There's that extra layer of confidence and trust that builds up. To digress a little bit about and just bring in a previous point is with regard to the polypharmacy also, is one thing we also make sure when a patient is on immunotherapy in particular is to avoid unnecessary antibiotic use, because right now we have seen many studies which say that usage of antibiotics bring down the efficacy of immunotherapy. And the third thing which we always make it a point to communicate to our geriatrician or physician, because most of the time once patients finish the cancer treatment, they are on follow-up with the primary geriatric doctor or the primary physician. We say immune-related adverse events can happen even as late as 1 year. So also keep a watch for that if there are unusual symptoms of that. So just wanted to bring about those 2 points. So geriatric assessment, again, we face certain challenges, and one is we don't have enough of trained paramedical staff or physician assistants as well to do this geriatric assessment, to take the load of the treating doctor. And I think if that need is addressed, I think in more and more hospitals, we would be able to have a better geriatric assessment done.
I would say, I think,
So,
I mean,
when it,
yeah, Dr. Tilak, yeah.
no, so rightly said. So, if, one hurdle of geriatric assessment with respect to the Indian perspective has been the Scope C, which devised by Dr. Joyita and her team, which is now going into version 3. So at least we have an Indian kind of assessment available to do. But yes, people to sit down and do it routinely in an OPD, I think that is a challenge at our setup also.
Yeah, and yeah, Dr. Manik, just to bring you in before we sort of take audience questions, I think Dr. Tilak has already answered. I think there have been rebuttals to that. So, so I think what would be, I mean, I'm not digressing, but what would be the ideal geriatric oncology setup according to, I mean, you can just briefly say, because ultimately what happens is I, as a geriatrician, would love to see all the older adults with cancer and make sure that the life of oncologist is much more simpler. And I can vouch for the fact that most oncologists who actually know about geriatricians' existence usually want to do that. But a lot of times it's all about sort of I mean, that older adults would not come back. I mean, they might have want to sort of make sure that everything happens in the same sitting. A lot of times when they, for example, somebody has a cancer and they come to you, they might be more sort of thinking about how we are going to make a difference as far as their cancer treatment is concerned, which a lot of times we might not have a direct answer to. So yeah, man.
Yeah. Thank you. And it is like it is not two separate entities or these things. Like a tumor board, it is like it's like a part of a coin, two sides. The medical oncology and the geriatric, which constitute the geriatricians constitute the geriatric oncology. So as a geriatrician, what I would like to see the patients is only two things. What is the quality of life of my patient, and what it will bring to the patients. So when patients coming to geriatric assessment, when they before going to chemotherapy, I would like to know what is the cancer, type of cancer, site of cancer, what is the progression, what are the treatment options available. And it's not like you screen with some tools, and if there is a score is high, you get a detailed geriatric assessment. Every geriatric assessment, every geriatric patient, before when they are treatment naive, before undergoing chemotherapy, they should get a detailed assessment. And what matters to me is what is the age, what is the expected life expectancy of the patient. what is the available treatment, what the treatment expected difference the treatment would make an impact on the life expectancy. And above all, what is the quality of life of the patient that matters to as a geriatrician.
I think one of the very important points which I want to
Prem
highlight
has
is,
stopped screen share.
what I would want to highlight is, I think the fact that a geriatric assessment is done is not enough. If we actually discover things, it has to be intervened, which is what obviously even Manik talked about. Like, for example, if there's a fall risk, to sort of make sure that the fall doesn't happen rather than waiting to treat the fall. And so that's, of course, one example. If there is frailty, if there is sarcopenia, we have to sort of make things, because a lot of times older adults are just branded as frail because of age, whereas they might not actually be frail. So, I mean, the chronological age and sort of the phenotypic thing should be something which should be kept into consideration. So I think the most important thing would be, if the oncologist and the geriatrician sort of, I absolutely agree, it's the same side of the, I mean, it's two sides of the same coin. We work together. Obviously, the fact that both of us are very goal oriented, and I think the quality of life is what is most important for both of us, whether it's with treatment or without treatment. And as we go, I think establishing a continuum of care is what we want. If the person is still not going to be treated with medications, that doesn't mean he's not being treated. Supportive care, when it comes to palliation. So we are actually continuing. So I think the questions have been answered. So I will just have final words from Dr. Tilak and then Dr. Nitin, and then Dr. Manik, you can close it. Yeah.
Right. My bottom line would be that over the last couple of years or so, my approach to geriatric oncology has definitely been strengthened by my knowledge of geriatrics. I have been able to make it more objective, and also probably make it, it should not be purely, what should I say, a template guided kind of thing, but more of a clinical decision making. If you use only the various codes, etc., and the charts available, that also is not right. You have to individualize it to the person. And but yes, objective decision making becomes important in geriatric oncology by using the various guidelines available.
Dr. Nitin.
Yeah, so I think one of the most important thing, which is the biggest challenge I feel right now, is people stigmatizing based on age. So you have, with no offense meant to anyone, you have GPs, orthopedicians, and anyone, whoever makes the first diagnosis, telling the patient and family, just leave them alone. Don't do anything. They have aged, and just going by the number. And this is where I think the knowledge of geriatric oncology and sort of a holistic assessment needs to be spread to the entire medical fraternity as well, apart from the general public, to tell them that, look, we have something which will objectively decide how much of risk a patient has, and these are the things which go into deciding a treatment. I think that is the first and most important point, and the challenge that we all need to work towards overcoming. And the second point is, I again rightly agree with both Dr. Tilak, Dr. Prem, and Dr. Manik, that it has to be goal-oriented, and at the same time, we have to individualize to each patient. And I think creating a cadre of health system which would be able to carry the geriatric assessment and then alert the geriatrician or the other allied specialties as to when an intervention is needed will also ease the burden and increase the acceptance rate of doing geriatric assessments.
Yeah, Manik, before you, I mean, there's a question I think you should be sort of be able to take it. Is there a formula or calculator to define physiological age, or is just subjective? There is a homogeneous criteria. We can have trials with physiological age rather than chronological age as parameter. That smile is actually giving the answer, but yeah.
Both are like very parallel tracks. So I would not go by a chronological age or these things. Rather than I would resort to the age. As a personal, there is no guidelines or no calculators or these things. As a geriatrician, if ask, I would resort to there are super ages. So I would restrict myself to the physical performance and the functional status rather than anything else.
I think I absolutely agree with that, purely because I mean, there are 95-year-olds, 97-year-olds are actually more fitter than 65-year-olds. So to actually put it only to that would be difficult. Yeah, Manik, your final word before I close it.
So as a geriatrician, my job is to identify the vulnerabilities for the geriatric oncologist And what matters to the geriatrician is only two things: what is the best functional, bringing the patient to the best possible functional status and the quality of life.
I think that was well put in. So, yeah, so I think as a geriatrician, as an oncologist, as a medical person, I feel we all should have very much goals which are there for the patient. But we have to remember that we need to know their goals as well. So I think to keep in mind what the person wants, whether their age is 65 or whether their age is 100, is very important. And of course, with knowledge, obviously, we'll be able to counsel them what would be appropriate for them. So thanks a lot, Dr. Tilak, Dr. Nitin, and Dr. Manik for accepting the invitation. And thanks a lot for whoever who's attended. Looking forward to meet you next month for another session. So thank